HOPCo has created clinically integrated networks. How did you manage from a governance perspective when so many other organizations in the market are just focused on the here and now, focused on the 5-year business plan, focused on growing EBITDA?
First of all, I think it's about the people, right? So our organization has a culture where, everybody is pretty honest about what they do know a lot about and what they don't know a lot about. And we make sure we bring in the right people with the right experience who are hyper-focused, our C-level executives, make sure that all of those divisions are working to build tools and solutions that are fully integrated. One of the questions we ask is, how is this going to further integrate and serve the entire organization?
Welcome to the next episode of Scale Community Technology and Innovation within Healthcare podcast. I'm pleased to be joined by David Jacofsky, the co-founder and chairman of HOPCo. HOPCo is the largest value-based care orthopedics platform in the country, and I'm very much looking forward to a conversation covering a lot of ground on innovation and excellence within the MSK orthopedic space. So David, welcome to the podcast.
Thanks for having me.
So maybe for those that aren't familiar with HOPCo, maybe let's begin with a brief overview of HOPCo. Where does the company focus? How big is the company? Where's your presence?
Yeah, so on one hand, we're a pretty simple business. We're the only vertically integrated musculoskeletal outcomes delivery platform in the world. But you can kind of artificially divide us up into our 4 verticals. Our first vertical is what we do with physician practice management. Our second vertical is what we do with facilities, specifically around hospital and hospital health system management. Our third vertical is our value-based care division. And our last vertical, which is our fastest growing vertical now, is our HOPCo Digital division.
Okay. And within, let's say, the PPM provider management space, can you give us a sense for your footprint? How many states, how many providers, how many practices?
Yeah. So on the PPM side, which, it's interesting because 10 years ago, our management services agreements with our PPM practices made up about 95% of our earnings, and now it's about 40%. So it's become a much smaller component of our business over the last decade than it originally was. But I think our physician practices are in about a dozen states. We have, if you ignore what we do in the value-based care realm, where obviously we have an order of magnitude more physician partners, I think if you look at just our true MSO practices, we have about 1,000 providers.
1,000 providers, so still fairly large. And as that segment, the PPM space, has become a smaller portion of the business, what has replaced that as the larger portion? Is that the value-based care segment, the hospital space?
It's really a combination of all of them. So, if you include hospitals, I think we're in about 30 states or so, and now multiple continents and multiple countries. We've had a big push focusing globally, both on the digital front as well as our hospital partnerships. But we've seen growth in both value-based care and especially in digital, which, as I mentioned earlier, is now the fastest growing part of our business.
So you really have 4 different businesses, which in some ways makes as you said, the business is simple and yet it has its complexities. It'll also make the conversation a bit more complicated because I imagine each one has its own value prop and way of functioning.
Yeah, I think that's true to a certain extent, but I would say the easiest way to think about it broadly is we're really the plug-and-play solution for physician practices, hospitals and health systems, payers and vendors that are looking to really transform themselves in the marketplace. And that can be anything from, us providing tech-enabled services to improve margins and market share to those that are interested in shifting from volume-based care to value-based care.
So let's start with a broad question to get under the hood of what HOPCo offers. So I'm particularly interested as these many times MSOs, but I'll call it specialty focused platforms, whether they're traditional MSOs or structured more like HOPCo, as they scale, as they invest in their infrastructure and their value prop, their ability to create differentiation in the market, their ability to enhance services to patients, their ability to reduce costs in the market. And from my experience, the specialty focused platforms do this better than anybody else, because if not the specialty focused platform, who's going to invest in building out that broad stack of services required to achieve better than outcomes? And so first question I have is, what has HOPCo achieved that, and what are the components of your business that allow you to achieve better than outcomes? So give us a flavor for what some of those outcomes are, and then from an execution perspective and a structural perspective, what it is that you've built that has allowed HOPCo to achieve those outcomes.
And from an outcomes perspective, I assume you're talking about sort of financial outcomes more so than the traditional clinical outcomes, or?
Clinical financials, better net outcomes to the market overall, preventative care, reduce costs, better outcomes to the patient in terms of service, in terms of quality of care, in terms of cost of care, integrated care, any and all of the above.
Yeah. So, I mean, I think there are a lot of things that we do differently, not to say that any other business models are better or worse, but they're definitely quite different. And if you look at HOPCo, unlike a traditional roll-up, for example, where in many cases they're a bit hands off and they're not necessarily doing things differently at the practice level, they're really going primarily for scale. We do it differently. So HOPCo itself is a tech-enabled service provider. So we have non-MSO practices, for example, for which we provide our customized EMR, for which we provide outsourced IT, outsourced cybersecurity, outsourced analytics, outsourced cloud-based phone systems, outsourced rev cycle, outsourced GPO and supply chain. So we provide those services regardless of whether you're an MSO or not. If strategically there are practices that are looking for a transaction, we're able to provide a transaction. But because we provide all of those services at scale, we are generally able to do an analysis up front of the practice and tell them, here are the services that we can do for you that would be less expensive and or enhanced. And they can decide if they want to do that. But in most cases, they do, and that allows us to drive income repair. So the vast majority of our practices see full income repair in 24 to 36 months. That's not universal because every practice is different. And in some cases, the road that they have to travel may be longer to get to where they need to be with or without a partner. But generally speaking, that allows us to do that. In addition, that allows us to do a few other things. Because of our value-based care infrastructure, we're able to provide value-based care help right away. And that may be in the form of quality-based national contracting within a fee-for-service framework within the organization, or it may be participating in things like our statewide URAC certified clinically integrated networks, where we take full global risk per member per month at scale, and through those networks allow, through ownership and bonuses, those physicians in the MSOs to almost have additional ancillaries. More specific to your question about preventative care and those sorts of things, we have teams that specialize in things like rolling out vein health programs, which are underserved in most communities and can have a big impact on outcomes. Interventional radiology programs, MRIs, additional ancillaries, which especially in the case of smaller practices, they don't necessarily have the infrastructure to be able to roll those things out, in an organized and rapid way.
And I would imagine things like ASCs play a big role in your business. Is that a fair
Oh,
statement?
absolutely. Yeah,
And
for sure.
how about preventative care, whether it's pain management, whether it's physical therapy? Is that also part of the spectrum, or are you really focusing on the orthopedics, traditional orthopedic services only?
No, we define, we talk about MSK and we define it very broadly. So for us, it includes orthopedic surgery, hand surgery, pain management, neurology, neurosurgery, vein health, PT, OT, really anything in the ortho-neuro rehab continuum, which is about 30% of the ICD-10 codes. And so we have a fairly broad definition. But because we do a lot of value-based care, we're very focused on preventative care. Right? I mean, if we can prevent a hip fracture, it's a whole lot more cost effective for everybody than treating a hip fracture. And so we have lots of different ways that we do that. Everything on the left end of the spectrum, which is educational programs for the participating providers, bonus programs, audits, tools in their clinic that allow them to make the best evidence-based decision that we can integrate into their EMR, all the way through what we do in some of these programs more directly at the member level with payers, which are things like digital clinics with triage to virtual care, hybrid therapy, in-person visits, initial visit with surgeons based upon how those patients are triaged.
You mentioned a clinically integrated network, and you also mentioned global risk. Are both of those concepts focused on orthopedics only? So when you say global risk, are you taking sort of bundled capitated risk within an ortho service, or true global risk across all types of care for that particular patient set?
Yeah, so it's a bit of a unique model. We certainly do things. I mean, we're the largest convener of orthopedic bundles, et cetera. We do everything along that spectrum from quality-based fee-for-service all the way to per member per month global risk. In our CINs, we're typically focused just on MSK, but it is a true MSK global risk program, meaning we're taking per member per month uncapped risk for that cost of care. So somebody goes to see their primary care doctor for knee pain, we're paying for it. They go to the ER with back pain, we're paying for it. They don't necessarily have to see an orthopedic provider. If they go through a windshield, we're paying for the ICU care for anything that's orthopedic related. So we effectively are carving out that total cost of care for 26,000 ICD-10 codes and effectively becoming the insurer for those codes.
What are some of the operational programs and what are some of the infrastructural investments you had to make to feel comfortable executing in that environment where you're taking global risk on this ortho MSK spectrum of care?
Yeah. So number one, you have to have the right people, right? So Rena Vertes is our president of value-based care. She's a former head actuary for Blue Cross Blue Shield Massachusetts. She has an entire team of data scientists, medical economics folks. And so you have to be able to price these things properly, and you have to really understand claims management and understand the data. Then you need the technology piece. And so the technology piece starts early. We have to have the ability to ingest 3 or 4 years of claims from payers in real time so that we can calculate the trends, we can calculate the cost per code, we can calculate, where are the areas of operational opportunity. And it's different in every market and it's different in every cohort. So if you're looking at a commercial population, your opportunities to save money are going to look very different than in a Medicare population. And if it's direct to employer, the type of employer is going to have a big impact. What kind of injuries do you see at a place like a FedEx versus an office setting? And so you have to be able to understand all of that. As you move down the line, you have to have operational programs in place to really manage the cost in the market. Because again, this is not just about the orthopedic surgeons, it's about orthopedic diagnoses in the market. So what educational programs can you provide for members to provide preventative health, everything from bone density to fall risk prevention, both from an educational perspective and an IT tool perspective? What can you do to educate the emergency department so that they understand who to admit, but more importantly, who shouldn't be admitted? And often are, because it's not good for the patient, but it's also unnecessary waste and unnecessary cost. And so we have teams of folks both in the field and in the office that help to manage those programs.
Are you taking global risk in the commercial environment, or is this primarily in Medicare Advantage?
No, both.
Interesting. And how do you think about, as a provider of MSK services, how do you think about discharging from a hospital? Do you have a network of rehab facilities that you work with? Are those owned facilities that are part of HOPCo? And then also, do you have any type of remote care, any type of home care that you're working with in that context as well?
Yeah, absolutely. I mean, I think specifically for hospital discharge, in addition to all of the, if it's an elective surgery, the preoperative planning, so that, site of care at the time of discharge is most appropriate. We certainly do that. We actually have teams that will go to in-network skilled nursing facilities, for example, make sure that they're following our protocols and pathways so that patients are optimized and discharged sooner. So it's not just whether the patients go to a SNF, it's also how many days are they in the SNF, because that drives cost. So we do a lot of that sort of work. The answer to the first part of your question depends on the program. So there are programs where our network identically matches the existing network for a payer. And the payer is still adjudicating the claims and the payer is still paying all of those claims. And any providers, any facilities that are in network remain in network. And so we then go out and work with those providers and those facilities. You certainly sometimes have payers or employers or risk-bearing entities that are looking to narrow networks. And if we need to narrow networks, we can use benchmarks to do that. In terms of virtual care, that's a big component of what we do in the HOPCo digital space. So we have the My Recovery app that manages patients, does patient education, does patient triage, does bundle payment, patient management, does virtual physical therapy, does patient reported outcomes, tracks patients, tracks their activity, interacts with them through two-way chat. You can send encrypted pictures of your wounds. And so we've really tried to create an all-in-one tool that we can use to engage with patients in real time that tracks not only their subjective responses from a patient-reported outcome perspective, but also objectively understands how they're doing, how's their activity levels, are they going up, are they going down, what does their wound look like, and can do that in very low-cost ways. And it's, from a socioeconomic perspective and from a demographics perspective is fairly broad. It's available in 6 languages. And so we try to make it as robust as possible to be able to engage as many patients as possible in as many ways as possible in these programs.
You're one of the few organizations I know that has managed to have the PPM space and then also provide hospital service line coverage. And so I want to spend a bit more unpacking what that means, but I guess maybe a segue to get there. Does the fact that you're providing the PPM services plus hospital service line coverage allow you to perform better in these global risk environments? Is there coordination across those two components, or do you think of them as really two standalone separate service lines?
Yeah, I mean, in markets where we do value-based care, where we have hospital relationships and MSO relationships, in some cases, those markets perform better. But I mean, we can build a statewide clinically integrated network in a state where we don't have an MSO or a hospital relationship. And again, then we just go out and we are educating and deploying tools in the marketplace with those in-network providers. So we don't, unlike, say, a bundled payment where you kind of have to have a group or a hospital convener, PMPM programs are statewide. And so even if it's a state where we have an MSO, we may not have an MSO across the whole state. So you really have to have techniques and programs and infrastructure to engage everybody across that network. But if you were to describe what HOPCo does in sort of the shortest amount of words, it would be market transformation. And I'm a firm believer that the fragmentation in healthcare and the sort of exponentially growing number of point solutions in healthcare is fragmenting healthcare even more. And we really believe that the future of healthcare will be led by integrators. And so whether those are data integrators like HOPCo or whether those are service integrators, we think that that's really important. And if you use patient-reported outcomes as a simple example, as that becomes more and more required, it's now required for hospitals to do. It's going to be required next year for ASCs to do. Lots of groups are doing it. If you're a patient and you go to see a physician for a knee replacement, and then you go to a hospital for a knee replacement, and then you go to a therapy group that does PROs, it's possible that patient is going to get 3 different surveys around the same time from 3 different organizations, and ultimately is going to then answer none of them. In markets where we partner with physicians and hospitals or health systems, we're able to rationalize some of that across the market so that everybody is getting one survey, and you're unifying the care for patients through data integration and then providing data that may include data from all of those disparate data sources at all of those disparate sites back to those stakeholders in one dashboard, for example.
So what is the service line? What does that include? Are you providing, is that just the data? Is it just the value-based care tool? Is it also providing physician clinical services?
So we have different programs. We really I'd bucket into 3 different products to simplify it. But one is our lighter touch program. It's called HOPCo Vitals, where we will effectively automatically ingest the data from all of the systems in the hospital, their EMR, their financial system, Coupa, or their inventory management systems, their anesthesia systems. We'll extract, transform, and load that into our high trust certified common data warehouse. We will then standardize and scrub that data and then give them real-time, anytime dashboards so that they can now look at things in real time. So you could look at contribution margin for the same case by doctor, look at contribution margin by service line, look at turnover time, first case on time starts by OR, by procedure, by surgeon. You can take all of the disparate data and now integrate it together to look at dashboards that combine different data sources. And it will provide you with recommendations against our national benchmarks for where you're underperforming. The second program is hospital service line transformation, which is where through a management agreement or a joint venture, the hospital will effectively outsource or partner with us to manage everything that is MSK. And that can include everything from capital budgeting, strategic planning, strategic marketing, the development of quality-based or value-based contracting, ASC partnerships, ASC development, ASC management, recruitment, expansion. We'll manage employed physicians for hospitals if that's something that they're interested in. And then our third program is our specialty hospital program, where we will manage and develop a specialty hospital, and those can be either freestanding or those can be what we call a hospital within a hospital, where we will effectively kind of quarantine a hospital area, a floor, ORs, separate entrance, separate branding, separate uniforms, separate key performance indicators for the staff, and create a specialty hospital for a health system with a health system.
Yeah, I mean, it's interesting as I hear this. Like, to me, HOPCo is sort of living out the dream of what we all hoped for with consolidation in this market. When you think about the different phases, I would say, first phase is consolidation. Market's highly fragmented. Can we get a lot of groups under the same umbrella to chip away at the fragmentation? And in phase one, there's still a lot of chaos because despite being under the same umbrella, there is lack of standardization and lack of organization. And so phase two is getting more organized, building more sophisticated programs, integrating, standardizing operations, standardizing systems, standardizing data. And then phase three is transcending. And you guys have transcended. You're no longer just a orthopedic roll-up PPM business. You're now an orthopedic management company in the fullest sense of the word, and you have found a way to deploy that as a service, whether it's to practices that you might not own or to hospitals. So it's fascinating. I mean, I think we'll see more of that in other specialties as these platforms mature. Are you seeing peers in other specialty markets take similar approaches as they mature, or is this something that's unique to orthopedics for a certain reason?
I think it's certainly these are certainly things that people want to do, and I think some of them are in the early days of starting to do so, and you've probably seen that. It is not easy and is very expensive to do, and so you have to make sure that you're doing it properly, because I think what we see a lot is people burn massive amounts of cash trying to create things that don't end up being adoptable in the marketplace. And so I think one of the things that has really differentiated us is the fact that we started out as a delivery platform, right? We started out as physicians delivering care. We started out as physicians that were leaders in health systems, and we brought on folks that have built these businesses outside of that. And so together, what that synergistically allowed us to do is develop products that fit into the workflow of providers and of hospitals. I think a lot of times what we see, especially with standalone tech platforms, is the development of a product by, say, engineers. And then you're trying to sort of figure out how do we deploy it and pigeonhole it into the workflows of physicians. And nobody wants to open up more apps. Nobody wants to have additional bolt-on products. What people really want is less logons and more unified, single solution.
You've got your own laboratories, so but once it's been through the HOPCo laboratory internally, it's sort of been battle tested, I would imagine, for third parties. Do you worry about, so as you move from an owned practice model to a service-oriented model on the technology side or with hospitals, do you worry about the stickiness of the revenue, the quality of the revenue, or are these all long-term, true, committed partnerships, whether or not they're on an own basis versus a service provider basis?
Yeah, in some ways it's easier when it's not an MSO. MSOs are always harder because the partnership is deeper, and sometimes expectations can become difficult on both sides. As it relates to the stickiness, I've always believed, whether it's in an MSO relationship or whether it's as a service provider, you always have to provide more value than you extract in the relationship. And if you don't, then you won't be sticky, nor should you be. And so ultimately, we've proven to be sticky, but I like to think that's because of the results that we drive.
And for the hospital, as an example, what are some of the outcomes that they're enjoying by partnering with HOPCo?
Improved contribution margin, movement of market share, improved outcomes, strategic partnerships with the independent practices in the market. For health systems, sometimes there's this battle between the employed docs, the private practice docs. And so a lot of our programs bridge that together, and sort of our programs can unify all of those different types of relationships into a program where everybody can win and lose together. Certainly there are markets where the health systems only want to employ, and certainly there are markets where the health systems don't like to employ. But in most cases, the hospitals have some employed physicians, and there are then competing private practice groups. And so figuring out how to get what are otherwise competitors to work together in programs can be challenging. And I think that's part of what we've done that is a bit different.
Yeah, I mean, this is another one of these big picture sort of market thing takeaways that we've had. We feel that one of the best things to happen to hospitals is the emergence of these MSOs because you have true specialty players that can deliver excellence within their core discipline in a way that a multi-specialty health system is not able to, just it's not feasible. But that's challenging to do because hospitals are slow to move and partnerships are difficult to forge. Can you give us a glimpse for how you enter that market and how long that took, and um, any tips on how to sort of develop those types of relationships?
I think as to how we enter a market, it can really start with any of our customers. So we can enter a market through a physician partnership or an MSO. We can enter a market through providing tech-enabled services to physicians. We can enter a market, in South Florida, for example, we entered the market through a partnership with a health system, and then we partnered with physicians. In Northern Florida, we partnered with physicians and then entered into a relationship with the health system. And then in some markets, we initially enter through a payer and then create value-based care programs. So I would say we enter through all three of those different options in terms of who is the tip of the spear in a given market. I think it's a bit of a flywheel, right? I mean, if you have customers that sort of speak highly of the work that you provide, it's easier to expand. And certainly as it relates to health systems, if you get in with a large health system in one market and you can improve their financial performance and improve their quality metrics, is then a lot easier to expand into other markets within that health system.
Let's shift gears to technology for a moment. One of the interesting items that I took note of as I was looking up HOPCo is that you made some acquisitions in the technology space. And so yet another sort of differentiating element of your development is you have moved beyond just homegrown and you've had a more diversified approach to technology where you've gone out and acquired certain off-the-shelf technologies in the market. So if you can share a little bit about how you think about the technology strategy, homegrown versus acquisition, and then maybe a little bit of detail about how those acquisitions evolved and what led you to make those transactions.
Yeah, we've always been a technology first company. Even if you go back to 10, when, to be candid, I thought we would be on the leading edge of value-based care when we started making these investments in 2005. And frankly, we were on the bleeding edge for quite a while. But even back then, when we had our early value-based care programs, we realized internally as a physician practice that we needed better tools in order to succeed. We needed to build customizations into our EMR for value-based care. We needed to have tools to track our outcomes and our costs. So we built those initially when we started doing that in 2005, 2010. We didn't necessarily plan to be selling them to third parties. We developed what we needed, and as it turned out, other people needed those tools as well. As we've expanded, and we probably, we run all of our software development out of our London office now. And as we've expanded, now I think we probably have 60 or 80 software engineers and programmers on staff. We always are deciding as we find additional functionality that would be valuable, whether we should buy it or build it. And in some cases, if it makes sense to buy, either because of intellectual property, time to market, cost, et cetera, then we'll do so. We are pretty diligent about making sure that we don't acquire anything for the sake of acquisition. A lot of people acquire things, I think, because it seems like a great idea and they want the press release, but I'm a firm believer that acquisitions can cause more problems than solutions in many cases. So, we have done acquisitions. I think that there'll be one or two more announced by the end of the year, most likely in the tech space, but we really focus on very targeted companies that are providing very targeted solutions that are best in class and fill gaps that we need and can be easily integrated into our unified platform. Because again, we don't want to just own a company that now becomes another point solution we offer. We want to acquire a company and fully integrate their functionality into our existing platform.
And if sorry, go on.
No, go ahead.
If an orthopedic practice wanted to buy the HOPCo technology solution, let's say, 5-physician practice in Massachusetts, is that something that you're selling as a off-the-shelf software subscription model?
It is. Yeah, and we have multiple, quote, products, if you will, although they're all integrated. We have our patient engagement tool, My Recovery, which I spoke about a bit earlier, really that omnichannel, omnifunctional, multilingual tool that the patients engage with the practice in. Then we have our HOPCo analytics platform, which is where we take all the disparate data from a practice or a hospital, and now suddenly the physician leaders and the C-level executives can literally in real time look up any data that they want. They can look at how, what is a physician assistant average cost to provide a hyaluronic acid injection in the clinic. And you'll suddenly realize that there are some providers that are dramatically different, right? And so what's our inventory turn? What's our par level per clinic for items? All of that operational stuff, really anything you could think about. How is this doctor performing compared to their budget for RVUs, et cetera? We can put it there at their fingertips. We have those two, quote, products, and then we also have our services platform, which is called CNS, Complete Network Solutions, where we will fully outsource IT and do everything for them, 24-hour help desk, cybersecurity, managing all of their integration work, rationalizing their apps, managing all their licenses, doing all their patching. And generally, we can do that for a lot less money than they're doing it locally given our scale, but we also can integrate everything in the cloud in one platform, including the phone system, for example, including our AI solutions. So we have really a few different things, but yes, we offer that to any physician practice.
So HOPCo has created clinically integrated networks. HOPCo has executed on global risk contracting in the market. HOPCo has moved from PPM space to providing services in partnership and to hospitals. And HOPCo has moved from being a clinical service organization to being a technology solution provider. That's not a short list of true innovation. And each one of those things is incredibly difficult. And I imagine took a lot of time, foresight, investment, patience, resources. The list goes on. How did you manage through that from a governance perspective when so many other organizations in the market are just focused on the here and now, focused on the 5-year business plan, focused on growing EBITDA? Now, this strikes me as a much more long-term vision and a much sort of less linear pathway forward.
Yeah, I mean, first of all, I think it's about the people, right? So as the CEO of the organization, I think my job is to make sure that I'm the dumbest one in the room, right? And so I think one of the mistakes people may make is thinking that they know a lot about A, so they probably should know a lot about B, C, and D. I think our organization has a culture where, everybody is pretty honest about what they do know a lot about and what they don't know a lot about. And we make sure we bring in the right people with the right experience who are hyper-focused on each of those 4 verticals to make sure that we're able to execute on them properly. And each of those divisions has folks that are in charge of them. Related to your governance question, then there are folks, in our C-suite, Will Barsoom, who's our president and chief transformation officer, a bunch of our C-level executives that make sure that all of those divisions are working to build tools and solutions that are fully integrated, although they're hyper-focused on building tools that service the particular functional area that they're responsible for. And so we really spend a lot of time making sure that when we approve projects, one of the questions we ask is how is this going to further integrate and serve the entire organization so that we don't end up with 4 companies, but rather one company that can provide all of the solutions in those 4 different verticals to any of our stakeholders.
Yeah, I'm just thinking about an example. I'm curious to get your thoughts. I think you probably saw the transaction a few weeks ago, GI Alliance, which is deep in the GI space, made its first acquisition into urology. And so that's another way of thinking about expanding. As these MSOs get larger and more sophisticated, they can move into different specialties. You have moved into different service lines, staying within the same specialty.
Yeah, I think yes and no. I mean, when we first started this business in 2005, we primarily were focused on joint replacement. And then we added spine, and then we added sports, and then we added foot and ankle. And now you look at what we've added, and we've added neurology and neurosurgery and vein health. And so we continue to add adjacencies. But to your point, other than our IT service business, which will service practices regardless of specialty because they're doing the same work regardless of specialty. So the IT piece we do for anybody, and we can do it for a whole hospital and a whole ASC regardless of how much MSK, if any, they do. But yeah, we've really been laser focused on MSK, and really two reasons for that. One is I think staying specialized allows you to provide really differentiated solutions because the depth of knowledge that you have is unique. And I think we've seen in the PCP space with value-based care, sometimes it doesn't go well. And I firmly believe it's because there are things that PCPs are incredibly good at that specialists will never be that good at. But then there are a lot of things in the specialty areas that PCPs might not be that good at. And when they try and manage risk in those spaces, it can be really challenging. So that's the first reason. The second reason is, frankly, the MSK space and the opportunity and the MSK trajectory in terms of growth of spend is so enormous that there's so much untapped opportunity within the space that we've not really had a need to expand into completely different specialties. I'm not saying that down the road there wouldn't be an opportunity to do that or to do that through joint ventures, but we really have had more than enough work to do what we're doing just in the MS case.
Yeah, no, I mean, I think there are many versions of the story. I think what's interesting is just at a market level, we're sort of at the early stages of seeing what the true full potential of these platforms are. And I think we'll see different forms of creativity, whether it's moving into management services, technology, multi-specialty. And so it's exciting to think about. I think there's some level of fatigue in the market. Some of these transactions haven't gone so well, or managing physician organizations is challenging, and all that's true. But we have these examples of those that are shining through and demonstrating excellence. And I think the good that comes with that is quite powerful. And I think HOPCo is a good example. So it's just nice to see. With that, a question about strategic partnerships. You mentioned primary cares, organizations that might take global risk, might not be equipped to provide coverage across all areas like orthopedics or cardio. How do you think about strategic partnerships? Are there other groups that you're working with to, whether it's primary care, you mentioned hospitals, so beyond hospital, that you're thinking about strategic partnerships with?
Yeah, so certainly on the physician side, as it relates to value-based care, we partner with lots of groups, and we look to partner with any risk-bearing entities. So whether that's a PCP MSO or an ACO, we love to partner with them and sort of be the plug-and-play solution, if you will, for helping them save money if they're risk-bearing entities in the MSK space. It's for oncology, for example, that's become pretty common. Most of these risk-bearing entities get an oncology patient, they have a partnership, and they have a way that they work with that partner, whether that's just to refer it out because they have a formal diagnosis of a malignancy, or whether it's ways that they know how to do the workup based on those relationships. That's not happened to that degree in other specialties, but I think that it will, and we're hoping to continue to try and drive that. And I think everybody wins in those partnerships. I think the specialists win. I think the primary care doctors win. I think the payers win, and most importantly, I think the patients win. So we certainly try and do that. And then in our clinically integrated networks, we obviously partner with MSK groups that we otherwise don't have relationships with as we continue to build out those networks. On the digital side, we have partnerships with Microsoft and Oracle and Dialpad and those sorts of folks. And on the value-based care side, we not only have partnerships with the payers, but large therapy organizations like ATI, where in many cases they're the front door for value-based care, or they provide opportunities to help save dollars.
Yeah, so it sounds like by taking the risk approach and being, I imagine, the contract holder, but providing the infrastructure, it's allowed you to think about maybe in a more flexible way what services you need to own versus partner. So physical therapy, it sounds like at least in some of your markets, you work through partnerships rather than owned physical therapy services. Have you found that since the model is based on value-based care, that you're limited by certain geographies where risk-based reimbursement is not as advanced, or do you see opportunity across all states?
I mean, I would say there's no question that specific to our value-based care vertical and that work, there are definitely geographic differences that are fairly stark. You think about the Northeast, for example, value-based care, definitely not front of mind for anybody, payers or providers. You look at Michigan, where you have one payer that effectively controls the entire market, and you have health systems that largely employ the physicians, challenging market for value-based care. And then there are some markets, the Midwest, Arizona, the Florida, North and South Carolina, where very progressive payers always looking to do progressive things, try pilots, and really trying to figure out how to really move from fee-for-service to value-based care in new and unique ways. So yeah, I think that there's definitely a lot of truth to the geographic differences that you see in value-based care. Probably more so for value-based care when we think about geographic differences in strategy than for anything else that we do.
On the topic of partnerships, how about employers? Are you entertaining any kind of direct relationship with employers?
Yes, direct to employer is definitely a big deal. And those are the sorts of partnerships where engaging and partnering with the large physical therapy providers can be helpful. Those are the partnerships where our, digital clinic are viewed as being highly valuable. And, I think that the world is changing for the employers. It's direct to employers is in some ways more complicated because they have a relationship with a payer generally for their overall adjudication of care, and then they have to try and carve certain components out. But I think more and more, as we have seen, especially with inflation in other areas of the business besides benefits, I think employers now are starting to get far more aggressive and taking more control over their healthcare spend. And certainly there are brokers in there that, I'll use the word, can complicate things. I don't mean that in a pejorative sense. In many cases, they're helpful to those employers, helping them find these solutions. But there are certainly a lot of stakeholders in the direct-to-employer market space that all have to become aligned around a solution in order for it to really get good traction.
How did you just resource even a direct-to-employer relationship? I mean, I would think that that's even an entire separate team to cultivate relationships with large employers and work through what in many cases is a lengthy negotiation and execution process to carve out MSK ortho services, as you said. Is that an entirely separate biz dev team within your organization, or is that more happenstance?
No, I mean, there are definitely folks that are focused on that within the value-based care team. And certainly, the direct to employer for us, but also nationally, has, is sort of lags behind what we do directly with the payers.
Mm-hmm.
But I would say, opportunities to do it as you think about it for others, the brokers can be helpful. The brokers are always looking for value add, but so can the payers. So in many cases, payers are going in and doing RFPs to take over benefits each year for these employers. And if you're able to provide them a lower cost digital solution and ways for them to offer those employer cost savings, you often can partner with the commercial insurer when they go in and help them potentially win that RFP. And so there are multiple different entry points into the employer. And then in some cases, in larger employers have an HR team that is aggressively focused on finding solutions to help them save money.
I want to end on a forward-looking question. So, clearly HOPCo has traveled quite a distance from, it sounds like it's early days where you were focused on joint replacement. Where do you see the company over the next 5 years? What do you see as the key changes in the MSK market over the next 5 years? So company level.
Yeah, I think it depends on what country we're talking about. Specific to the US, I mean, I think value-based care will continue. I think it will continue to expand and grow. I think one of the limiting factors which surprises many people is actually the quality of the data that the insurers have and can provide. And so I think some of the more progressive payers are now starting to figure out how to mine their data differently to provide better solutions. We in many cases are taking their raw claims and creating useful data from it. But a lot of organizations don't have the ability to do that. And so as the insurers can start to provide more meaningful, useful, and in some cases accurate data, I think we'll see more and more providers and health systems willing to engage in value-based care in a meaningful way. I think the tech-enabled aspect of the services we provide will continue to expand. We certainly are continuing to think about how we're using AI, how we're building AI into our platforms. In order to improve efficiency. And I think when you think globally, there are a lot of countries that are far behind the US. In some cases, they're ahead as it relates to the spend and their costs, but as it relates to access or specifically surgical ambulatory surgery centers. We're doing some ambulatory surgery centers in a few countries, the UK and others, where it's one of, if not the first, one of the first in those markets. We're seeing countries that we're working with where the average length of stay in the hospital for a total joint is still 5 or 6 days, whereas in the US, we're doing that stuff generally either outpatient or less than a 48-hour stay, certainly. So lots of opportunity there. And, global OUS has become a big focus of the work that we're doing.
I couldn't have asked for a better answer. I mean, I think 1 out of 1,000 CEOs would, when asked about the macro market landscape, would think about bifurcating their answer, US based borders versus global. It's another key theme that we are focused on and thinking about, which is the management best practice that's being developed. Yeah, it's more challenging to export to other countries for various reasons, but over time, does it get more and more exportable? Do we start thinking about best practice cross-pollinating across countries? And it sounds like not only do you think the answer to that is yes, but you're already well on your way to experimenting in that area. So maybe one true final question. I would love to hear a little bit more about your thoughts on and your progress in expanding globally and your thoughts on further expansion globally over the coming term.
Yeah, I mean, I think global opportunity right now is huge, and that's not to say that there aren't a lot of things other countries are doing better that we're learning from. So in the
Sure.
UK, for example, they are very evidence based, far more than here. NHS is really focused on national recommendations, and so you look at certain things like how much physical therapy and when physical therapy should be used, and it's very different. And so we have a lot to learn from OUS as much as they have to learn from us. But I think ASCs, as I mentioned, and value-based care are both things that are farther behind OUS than in the US. And so we're very excited about growth in the UK. We're very excited about growth in Germany. We're very excited about some of the things that we're getting ready to do in the Middle East. And we're very excited about what we're doing in Australia. In the short term, I think Australia and the UK are probably the two areas where you'll see HOPCo with the fastest growth over the next 24 months. But as we sort of look farther down the road, I think that the Middle East and Germany are areas where we're really leaning in.
So we can add direct to employer relationships and international expansion to the list, along with the others that I mentioned: clinically integrated network, global risk, hospital service, technology service, on how HOPCo has innovated and demonstrated its leadership. It's a remarkable list. Fascinating conversation. So David, I really appreciate the time, and thanks so much for coming on. I learned a lot.
Thanks for having me.